Welcome to Airway Answers, expanding your breadth of knowledge. My name is Nicole Goldfarb, and I'm a speech-language pathologist and certified orofacial myologist. And I'm here to help you find your airway answers. We're in this together. Let's do this. Hello, everybody, and welcome to Airway Answers. I have Dr. Stefan Decker here. Thank you for joining us, Dr. Decker.
Thank you, Nicole, for having me.
It's just so exciting to have you on. Dr. Steve Lamberg is like, you got to get Dr. Decker on your podcast. And I knew of your name. I always see comments on social media. You're always active, providing input. And then I listened to your podcast with Dr. Mike DeLuke for the Doc Podcast. I listened to your podcast with Dr. Becker from ASAP Pathway. And we have so much good stuff to cover today. So I'm really excited to have you, and knowing you're an orthodontist makes this even more special. An orthodontist that truly gets holistic health, airway, how the teeth are connected to an entire body. We're not just making ourselves look pretty by aligning teeth, which is a very important component to your treatment, but we're actually thinking about breathing and overall health. So I'm going to go through your bio, and then we'll get talking. All right. I know we're going to have fun.
Go for it.
You and I probably have similar energies, so we might just like blow up the screen in excitement. Okay, here we go. Dr. Stefan Decker has been an orthodontic specialist since 2012. He completed his primary dental training and his specialist training in Germany, Switzerland, and the US. Dr. Decker is highly trained and experienced in early interceptive orthodontic treatment from as young as age 4. And I think on one of your podcasts, I might have been with either Stacy Becker or Mike DeLuke, you said 4-year-olds are better than any adult you've ever treated. And you also said, I'd rather see 10 children than 1 adult. We got to talk about that, because I think most orthodontists, those young kids, those are kind of scary to treat. There's less training with dealing with and managing behavior. So it's really going to be interesting to hear your perspective on that young age group. But I'm going to finish your bio. Dr. Decker considers the whole patient development throughout his treatment and connects the dots between breathing, teeth, function, and development. In getting the structure of the arch organized at an early age, Dr. Decker believes we can improve breathing. The risk of teasing at school or traumatic damage to the teeth is also greatly reduced. He's one of the world's leading clear aligner providers in children and lingual orthodontists, having treated over 1,300 lingual orthodontic patients, and has served as a member of the Global Advisory Board for 3M and Align Technology, and has been their clinical advisor for Western Europe for 3M. He is the director of the Orthodontic Specialist Academy and was the official Invisalign clinical speaker lecturing worldwide, and is now a KOL for Angel Align. Did I say that right? KOL?
Correct.
Okay. Dr. Decker is also, as well, the first and only Coyce recognized specialist in the UK, and John Coyce is scientific advisor for orthodontics and airway. That's awesome. One thing, I looked on your website also, and your practice in Amersham, Buckinghamshire. How do I say that?
Buckinghamshire.
But 4 syllables, Buckinghamshire.
Yes.
Okay.
It's where the Queen lives, near where the Queen lives.
Yeah, because I'm like, I think I've heard that. It's a beautiful word, 4 syllables. As a speech pathologist, I got to do my multisyllabic word breakdown. Buckinghamshire. Okay, so at your practice called the Orthodontic Specialist Practice, your website says you prioritize the physical, emotional, and mental well-being of our patients across all age groups, ranging from children to teens to adults. So I just love that, because I don't know how many orthodontic practices do talk about physical, emotional, and mental well-being as part of a treatment. And also the goal is to emphasize prevention when possible, but you also understand that some individuals may require corrective treatment, but it's not all about teeth. This holistic approach allows our experienced clinicians to assess various parameters such as oral, skeletal development, tooth eruption, breathing, and tongue position, ding, ding, my favorite words. These factors are interconnected and contribute to the development of the face and teeth. So you take those into account in your treatment plans. Thank you for being here, Dr. Decker, again.
Honestly, thank you for giving the opportunity to raise more awareness because, as you mentioned, I'm quite alone in this world of orthodontics speaking about these connections because most commonly dentists are more familiar with these topics than orthodontists are. And I find it such a shame that orthodontists are so close to these interconnections. So I'm very happy to be here because hopefully I can inspire some of my colleagues in the world to go down that route because we have to.
You have to. It's no choice. And I think our goal is really opening people's eyes to seeing this. And that like really common saying, once you see it, you can't unsee it. But it is so true. And a huge majority of patients showing up in orthodontic offices because of dental malocclusion, skeletal malocclusion, have underlying airway issues, orofacial myofunctional uh, disorders are either the cause or a significant contributing factor to the reason why they're seeking orthodontic care. And if the orthodontist does not understand that, they're potentially missing a huge component to the treatment, to the lasting effects of the treatment. These patients are at risk for relapse, but also to that health component that really is the foundation of what's going on.
Absolutely. And especially look in orthodontics, we all talk about biomechanics, on how to move teeth, and every orthodontist goes on conferences and learns about different tools on how to move the teeth. But we don't actually learn on where we should position them correctly from a function perspective and from an airway tongue perspective. So basically, I always say you can be very good in biomechanics and using different tools to move teeth, but if they are incorrectly positioned at the end of it, it will relapse and it's not good. So, but I have to honor actually my first boss. When I started training in 2008, my boss, when we changed the bite, we always had an osteopath coming to the clinic, measuring the leg discrepancies with different bites I took in when I did functional orthodontics. So I realized that actually, depending on what I do up there, the body is adapting in different ways. And at that time, that's a long time ago, nobody did that. And I thought, why are you doing this? This is not orthodontics like I learned at university. How are the toes and legs connected to the way you're biting? And at the time, I didn't think too much. I thought that was normal because I was freshly in training. So I thought this is the norm because she trained me to do it that way. But then when I came to England 10 years ago, I realized there's nothing. There's no speech therapy. There's no myofunctional therapy. There's no nothing. So basically, I had to get away from kids' idea of holistic approach, getting everyone on board to thinking, okay, in central London is only adults. They want help. So it's all about cosmetic, about aesthetic and smile. So I had to learn to be very good in lingual braces to treat adults, ignoring everything I had. And about 6 years ago, I went back to kids and I thought, I need to try this again. I need to try to get these people on board because that's what my training was. But trust me, it was the hardest thing ever to get these people. And like you and me know, when you're on social media and you do a podcast, suddenly it takes a while to get people to acknowledge what you do, and then they suddenly come to you. But finding them is so hard. And when I train people, I tell them all the time, I will teach you the connections, but it's up to you to get it all treated. And that's a really big task. And what we are doing is so important that people get to know the people who think the same way. But it's very, very hard to find.
Yes. And I want to talk about lingual orthodontics because that's a specialty area that you started out in. What does that mean, lingual orthodontics, lingual braces?
So basically in 2008, 2008, it was there was nothing like Invisalign. It wasn't as popular. It was a tool that doesn't work. So the only device that was cosmetic was a fixed brace on the inside of the teeth. And biomechanically, it is superior to an outside brace because it's custom made. So I went and treated all the teenagers with lingual braces, and I went to London. I treated all adults with that. So I basically treated everything that went wrong with the liners with lingual braces, fixed braces. I was in charge of it. It was nothing removable, so I could achieve goal. And it was invisible because it's on the inside. It's not hardly visible, it's invisible. And a lot of people liked it. But of course, with aligners coming more and more on the market, mainly the dental market, because they attract the dentists to do it, I become very, very in demand, and the prices dropped because more and more providers use aligners, and the prices dropped. So I couldn't compete with that anymore. So I was in a state in my life where actually I felt very depressed because I did a lot of education, a lot of training to become who I was, but I couldn't compete with this price going down, 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 down by all the dentists. So I reached a point where I said to my wife, why do I do all this? Because all I treat is the people nobody else wants to treat, which is a very complex case. Now we're not talking airway at this point. It was just about teeth. And when adults have teeth issues, sometimes they become a bit crazy, and they have demands that you cannot fulfill. And that's what I said in the other podcast is a kid, you treat a kid well, they love you and they give you a hug. You treat an adult well, they might like you, but they might not, even though the teeth are straight. So I really struggled with that. I said, hold on, I tried my very best to help you, but you're still not happy. How can that be? A kid is, you treat them well, they're happy because you did a good job. And about 6 years ago, I went to John and learned everything about destruction in adults. So I look at all of the cases because my wife is a restorative dentist. And the first thing she said to me in 8, 9 years ago is, have you seen your cases failing 30 years after you completed them? And I thought about her, what do you mean? We move everything into class 1. That is how we've been trained to do. What do you mean it's not failing? So she showed me failures. She showed me the adults that came back 30 years later with the same problem as a kid or worse because they had extractions or something else. So I opened my eyes. I went to see John and I learned everything about restorative dentistry and how to rehabilitate, how to help these adults in restorative world. So I understood dentists. I said, okay, they're dealing with all of these problems in adults. But then I looked at all of these cases from John and I thought, all of these cases, a lot of them have a tongue tie. And the tongue is low. So that's why the upper arch collapsed. That's why the teeth moved in the wrong position. That's why there was trauma on the teeth, which caused recession, abrasion, attrition, and all of the rest of it. So I said to John, do you know that your cases are tongue tied? So he said to me, what do you mean? So basically, he opened his eyes to something, show me some research. That's John. So I sent him some research, said, okay. And then he sent me a CBCT from his granddaughter. And there were adenoids, tonsils, and everything. She was 4 years old. And I said to him, this and this and this is wrong. That has an impact on her. She might be snoring, etc. So he said to me, Stefan, I need you to speak at my symposium. So I talked about what I do in kids, in seeing these signs, because these are the first signs. And if you don't notice the opportunities, that gets worse and people adapting to their problem. And as an adult, you deal with the consequence. So, and the consequence sometimes is very, very hard to treat, much harder than a kid. So that is where I met Christian Leonhardt at a symposium. He's German as well. So he talked about adults. So John connected us, kids, adults. Let's talk about the whole lifespan of dentistry. What happens if you don't notice these opportunities as a child? What do you need to do in adults? That is where Tracy all talk about MAPE, dome, and all of these techniques because adults. But how complex is this topic? If you want to do adults, you need to be really good in diagnostic, CBCT, everything. You need to consider everything, sleep test. But when you treat kids, you see signs. You look into a child's face and you see they're sad. The eyes are going down, venous pooling, trilips, facial structure, mouth breathing. And these are only tiny little signs, and they might not communicate it to you because they're kids, but you see it. So then you do a tiny little change. You encourage the craniofacial structure to develop, and suddenly you see, they look so different. They're so much happier. And you realize, oh my goodness, what am I doing? Forget the teeth. Look how much better they look. And to your area, when you give the tongue more space, they speak properly. If you give a tongue more space, the tongue positions correctly. If the tongue positions correctly, they can breathe better. So over the years, I realized, wow, it has nothing to do with teeth anymore. This is now, I develop structures, make sure the tongue has enough space, make them breathe through the nose, and kids feel better, behave better, are just better human beings and are healthier, and you see it in their face. And this is for me the most rewarding thing I ever had. And when you do that every day and you have a lot of patients who travel to you far and you treat Down syndrome children, then you realize, wow, this is your superpower. But only your patients can benefit from that superpower. I need to do something different. So I thought, okay, I had a few dentists who then brought their children to me. I don't remember, before I never had a referral because the dentists do everything themselves. So they brought their children to me. And then I said to a dentist, why do you want me to treat it? You should treat it because you are in Wales, in Hong Kong, wherever you come from. Why do you travel to me to London to treat your daughter? Do it yourself. So I realized by me training dentists or orthodontists to do kids, more kids get help. So my mission now is to help children breathe. And the more I can do it, the better. So I need to educate. I need to do podcasts. I need to get out there to train people because this way more kids get help. This is why we're here. So it was a journey. And when you self-assess yourself in psychology, I was always someone who cared for community, who did neighborhood help. So my basically someone who talks to me every week, he said, look, Steffen, it's very simple. You found your destiny. Your destiny, you want to help anyway. With kids, you get love. You want love. You want connection. This is what makes you stronger, and just this is your thing. So go and fly. And that's what I'm doing now. I'm traveling every week to different countries, teaching about forget the teeth. Yes, teeth show you a symptom, crooked teeth. But ultimately, when they are that way, there's something else is showing you as well that something's not right, the way they're functioning or breathing. And if you change that, that has ultimately much more impact than the teeth. And if you ignore it, you can align the teeth, but it will come back. So we have a relapse. And in UK, nobody understands that. So in UK, I'm a single warrior in the whole space. And this is for me very, very sad because I need to travel far to feel heard and listened to. So it's very emotional journey for me, but I'm so glad only because what gives me back to my profession, to my passion, is there's no value to it, and that is what my determination is. My passion now is to spread the word and the necessity to see the smoke. Otherwise, you will treat the fire.
That's a really good saying. See the smoke, otherwise you're going to treat the fire. We need to look for red flags and symptoms. And
Correct.
oftentimes, and I say this in my presentations, Signs may appear before symptoms even do. And you can see problems in children very young. And in your interview with Dr. Stacy Becker, you said the teeth tell the story of the wellness of the child. And that is so correct. And I want to dig a little deeper with that. I feel like also I hear you saying you feel like lonely in the UK because there aren't many people who see things the way you do. But the wonderful thing about technology and the virtual world is we're all connected, right? Like we are here on this mission together, so we can be far apart and reach people, reach an audience. I think a lot of parents and
You know,
are hearing
and
this message.
also,
Mhm.
I know for sure if we ever meet in person, the first thing we will do to each other is give each other a hug.
That's what I
Why?
was gonna say.
Because we both care. So what I realize in my teaching as well is the people who listen, who take the time to listen to what I have to say, they come back to me and says, thank you. Thank you for inspiring me. Thank you for opening my eyes. Thank you for helping me and my children. So, and that comes a far way, that this connection, this warmth. So I know everyone I meet online, only on social media, and you are right, that feels me more connected. Whenever I meet you in Penny or wherever we are in the world, we give each other hugs, says, it was amazing. Thank you.
It is so true. And my favorite thing is to go to these conferences and see all my Airway tribe. It's like this family that, like you're saying, I might not have met this person in person. And we see each other, and it's like we know each other so well because we're on this like unified mission. We know the importance of recognizing these issues in children at a young age to really change the life, the health, the quality of life of the child and the entire family, because we've all been there and we've seen it firsthand. And so we are all like family members. It's like fate. Like like how I came into this field, it's just weird. Like everything happens for a reason. And I've
Hmm.
had struggles with my children that have been rooted in airway issues. And firsthand, it's just I don't regret that. It all happened for a reason because now I see it and I can help so many more people from my personal experiences.
And this is exactly it. It's about emotion. Like people see patients as a job. But then when they listen to us about signs and symptoms, snoring, positioning, hypotension of the neck, they suddenly go and think, hold on a minute. When I checked last my daughter or my prince or my princess last night, they had exactly what they were talking about. So they think, forget my professional hat now. Let's put my parent hat on. Says, my kid is struggling. So then they come to you. And that is the biggest thing I've noticed. In London is so competitive that you never ever get a referral. Never. In adult market, no chance. But since I'm on this kids venture and I talk about prevention and the need for prevention airway, I have more and more big names in the industry, in dental industry, coming with the young children for advice. And then they have their guards down. They're not these competitive business people, they're their mom and dad. And then it's very nice connecting with them because there's no ego. It says, please help me to solve that with my child. And that brings us all to the same level. And that's nice. So, and it's emotional connection. It's your family member who's affected. Might be even your granddad who has had sleep apnea and a CPAP, all of these things. So a lot of the people, like you said, who are in this space have personal experience. And that makes it super emotional. And then when you go into the space and you treat especially kids in need, like Down syndrome children, wow, you have not seen the problems they're going through in life and what you can do by changing craniofacial structures. It's unbelievable.
It's so amazing. I want to hear if you have any stories or examples about any of the children with Down syndrome that you've treated. That would be really interesting to hear. Do you have any cases on your mind?
Well, I tell you just one case, that's my oldest case. He's now 10 or 11. But since I treated this one case, I have now five more. For some, I have not even talked about or published this case, but people talk. And today, I had an 11-month-old Down syndrome child in my office. 11 months. Because they wanted my opinion on what they can do now, before any symptoms come. And I said, I'm so grateful that you come now, because I tell you, massage the palate, stretch the tongue, get nasal rinses going now, because it starts on the nose stuff. So Jackson, that's my Down syndrome child, he's 9 years old. He came to me and he had lost several teeth already, steel crowns, infections, complete blocked nose, couldn't hear, posture adaptation, open mouth posture, CPAP since he's 4. So I put my logic hat on and said, okay, what can I do? I've seen the palette. It has something Christian and we call the fjord shape. It's like a very narrow part. So that what I can do is I can open the palatal structure, which should open the nasal base, which should decrease the resistance for airway. That's as simple as it is. Okay. And eventually that will make things better for you. I can't promise you the world because airway is multifactorial, but I try. So I did that. So suddenly his ears popped, boom, and he got movement in his ear. So he started hearing.
Yep. Right
So
on.
I thought, what? Confirmed by the doctor. The ear started moving. Doctor wrote me, says, who are you? What are you doing? Hearing. Next thing is snoring stopped. Boom. Next thing is he started speaking. The South African, which is very hard, he could speak better. Next thing is that his symptoms decreased, less infections, and then he suddenly could close his mouth at night, and breath was breathing through his nose. So his oxygen levels increased. So this is all within a 6-8 month treatment period of time, by you just widening the palatal structure. So I thought, wow, wow, wow. Nothing of that. Who cares about the teeth?
Yeah.
Hearing, speaking, infections, his face developed naturally. Said, this is so emotional. And this is the longest Down syndrome I have in treatment now. And since then, 2-3 other Down syndrome with 11, 12 started now and do the same thing. Is there a lot of research? No. So of course it's a journey. I'm aware of the low tongue tone and everything like this, but I never promised I will heal them. But I said I will try everything in my power to help you. And that help will probably go on until I don't know what age. I don't care. But these Down syndrome children is, you are coming back to give me 10 kids instead of one adult. These Down syndrome children are the most loving patients you have in your dental office.
Mm-hmm.
So he comes in and gives everyone a hug, and it's
Yeah,
just,
that's so sweet. Yeah.
no, they're happy.
Yeah.
This is what is important to me.
Yeah.
This loving, caring behavior. And it is hard, yes, and it takes me years, okay, but doesn't matter. So it's a venture I'm on, and they're getting younger and younger. And unfortunately, I can't do a lot in an 11-month-old Down syndrome child, but I can help them in every knowledge I have.
Yes. Well, get that kid to a speech language pathologist that has early intervention training. So that birth to 3-year age range in that oral sensory motor aspect, feeding, if they have training in myofunctional disorders, those kids can really benefit. And I'm sure you're familiar with Linda D'Onofrio. She's wonderful. And one of the things she said, and I might not be quoting it correctly, but Down syndrome is a genetic disorder with an orofacial myofunctional disorder on top of it. So if you treat the myofunctional disorder, you can really change the facial structure and the appearance and the breathing, the speech, the functioning of that child. But a lot of times, especially at the younger ages, it's going to require that really trained FLP. in that domain. But those kids can do great. A lot of my colleagues work with young children with Down syndrome.
If you have anyone here in the UK, please send me that, because I need that here in the area, because I get more and more, and that's not my expertise. I always I say to them, you need to get these muscles stimulated. Any muscle they have, get stimulation, because that will shape a lot of things. So it would be very grateful for me to link you up to some of these, here in London or UK. That would be
Yeah.
perfect,
If
because
people comment on, make a comment. I'll try to reach out too, because I'm sure there's colleagues who are all connected who might have specialty areas, speech pathologists, myofunctional therapists. So I will try to help find you connections, because that holistic treatment, the skeletal component, the muscular component, can benefit these children so much. And it's no surprise that by expanding the palate, you're helping with the hearing, because we know those children with narrow palates are more likely to have high risk for ear infections, and just simple
of
expansion
course,
alone, right? Reduced by pulling those muscles taut to help the eustachian tubes drain the middle ear.
you wouldn't believe how much resistance you have here in the UK. They say, no, take all the teeth out. Let's just wait. And you go down this rabbit hole of symptoms, 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 symptoms. And the parents getting told, this is your fate. I mean, it's so sad. Even today, the parents told me of this 11-month-old kid. They were told to abort the pregnancy because we have a Down syndrome child with a healthy heart, but it's not worth living. I mean, it's wow. I mean, how can you do that? I
Oh,
mean,
yes. Those are the sweetest kids. When I worked in a school district in a preschool, and oh my gosh, I loved those children. They're
no.
just so kind and just so innocent. They're just really sweethearts, right?
And today I started massaging the palate. For every time we talk with me, I continue. I started massaging the palate already. The kid was addicted to me.
Yeah.
They wanted more,
Yeah.
more, more. So
They
I just
appreciate that
continued.
sensory feedback. I've had a lot of patients with Down syndrome really grind their teeth. They need that like stimulation. So that's interesting, that just that oral massage at that
And he
little.
grabbed my hand and wanted
He's like,
more,
more.
and it
Oh, get
was
him
so
a mile
nice to
munchie.
see.
Okay, this
Maya,
is good.
absolutely. So I
Wow.
said to parents every day, please just do this. And the tongue started moving, and because it was 11 months, it was the youngest Down syndrome I ever had. So I just tried everything I knew and see what response I got. It was didn't cry anything. He wanted more and grabbed my hand. We took pictures. It was
Yeah.
so heartwarming.
Yeah, the kid, that's so great. And this leads me to a question about primary teeth. So the baby teeth on children, when they look perfectly lined up, no spaces, parents get happy. Things look great. But is that considered malocclusion, or maybe pre-malocclusion, if there's such a word? Let's talk about that so people understand.
So basically, we are trained. Malocclusions are cross bites and over chats and deep bites. But a malocclusion, baby teeth should have gaps. We call it primate gaps. So there should be spaces in between. But most dentists are not aware of that. They say they're not crooked. There's no deep traumatic bite. There's no increased overchat. There's no crossbite. Hence, there's no problem. And a lot of people don't actually even screen. They don't take any diagnosis, no x-rays. So they don't know how big the permanent teeth below actually are, how much space they do require in that kid. Because it's not about static measurements. The tongue needs a certain space. So the tongue is very individual. They can be bigger, smaller, whatever. So we cannot go by static. So a malocclusion is not identified in baby teeth. So, and also the interesting thing is like the AAO, the America, they say from 7 years old we should screen. But where is this coming from? There's no evidence. It is just a convenience thing that the first molar should be there to have more teeth to anchor something on. But it's not based on any evidence. Versus it should be whenever there are symptoms and we have a patient who understands the symptoms and is compliant to work with you, that is when we should start, independent from the age. Age, what does age say? Because the age is also changing. If you look at the eruption pattern of teeth, we used to say at 6 we get the front teeth, but now it's more towards 8 because they don't chew properly anymore. The craniofacial structure is shrinking. The teeth have no space, so it takes them longer to come in. Just logic, common sense. So we need to get away. And baby teeth, I'm not saying every diseased dentition needs to be treated, but if there are any symptoms or signs, red flags, that the tongue doesn't fit in there, then we should consider giving the tongue more space.
So if there's a child whose primary teeth, there's no spaces, but the child doesn't have any physical or behavioral symptoms of an airway problem, but we know adult teeth are not going to fit. Would you want to treat that child at that young age?
100%, because
100%
he might not have symptoms yet.
yet. Mm-hmm.
So,
That is the sign before the symptom.
so basically, this is the lifespan of dentistry. I can say to a mom, okay, look, there's no spaces. The teeth, the permanent dentition is double the size as the baby teeth in front of it. If we don't intercept right now, the chances are very high that the teeth come in a shark position or the teeth come in delayed. So now they have a choice. Okay, do I listen to him and intercept now, create a space now, or do I wait for these symptoms to happen? Trust me, when they do happen, they come because you told them they will happen. So it's all about a matter of when they're going to happen.
What kind
And
of symptoms might you tell a parent might occur?
tooth grinding, posture adaptation, mouth breathing, asymmetric chewing function, asymmetries in their face, wear on teeth. So there's a lot of things. And delayed eruption of permanent teeth. So, and when you have diseased dentition, let's go into a deep bite. So John Coyce talks about a constricted envelope of function. In adult dentition, we have wear on the adult dentition in the front because when they chew and in function, they're going from the outside in, they're touching the front teeth on their way to their home, MIP. But that creates wear. So now you say, okay, adults have wear, but do kids not have wear in diseased dentition? Oh, yes, they do. Because a kid in diseased dentition with a deep bite has also an envelope of function, but everything is just developing around that new envelope of function. So they're adapting to that function. So they're also grinding their teeth away, but their team J is not set yet. So they might not have symptoms, especially they're not communicating symptoms. They don't tell you, oh, my teeth are moving, I have team J pain. They're 4 or 5 years old. So everything we see in adults, I see in kids, but they're silently suffering. And then you can say to a kid, okay, in your consultation, say, okay, if you don't do that, then when the permanent teeth are erupting, they will be in contact. So they will wear down or they will move backwards and up. They will develop a curve of speed. Then we get constriction, we get wear. So eventually you will see one of the parents raises their hand and says, excuse me, this is me. What you're describing, my son, my daughter will develop into is me 30 years later. That's what my wife always said. Have you seen your cases 30 years later failing? So the kids, they don't tell you. You need to be really good in diagnosis. But you need to understand what destruction happens in adults to understand where are the kids heading towards.
Okay.
It might not always be the case, but the likelihood is very high. And a lot of times it happens that the mom says, but I had crooked teeth and I had the teeth taken out and I have airway issues now. Everything you said happened to me. I don't want my child to go through the same thing. Where do I start and how much does it cost?
Yeah. And what
So,
kinds of treatment do you do on these young children?
so now let's go back to John Coyce. So in adults, when we have a constricted envelope of function, we open the vertical dimension. So that helps them to get them out of constriction. So now in young children, we can open the vertical dimension. We can do a myobrace, opens it up. We can do a tooth pillow. We can do Vivos. We can do an aligner with Bitrams. We can do an equiplan. There are a lot of different devices that open the vertical. And then suddenly the jaw can move freely. The jaw comes forward out of constriction, opens the lower airway. Everything we do in adults, you can do in kids. It's just a different tool.
And probably a lot easier in the kids.
A lot easier. You don't even think about it. A myobrace or a tooth is a device anyone can get remotely. Put it in, it helps, especially when the tongue is then developed to go up. We strengthen the tongue muscle, the lip muscle, nasal breathing. Suddenly everything starts to correct itself. So it's so much easier because in adults, even you open the vertical, you still need to restore the back or need to do orthodontics, and it costs a lot of money because to fix the problem costs money. So the power is literally in young children. And let's stay with vertical. When teeth are erupting, it opens the vertical dimension. So now we have a 5-year-old kid. Now what will first erupt is the first molar, permanent molar on the back. This is your opportunity that the molar can erupt into a new occlusal plane. So if you open the vertical and the teeth start to erupt in a new dimension, you open the bite without doing anything because the teeth are just growing. First opportunity. The first opportunity is when they get the teeth when you're breastfeeding. Because you're breastfeeding, the jaw gets moved forward, gets lip sealed. The teeth start to erupt into that occlusal plane with the jaw being moved forward because they need seal to get the milk. First opportunity. A lot of people nowadays miss that opportunity because they don't breastfeed long enough, or they cannot breastfeed because of tongue restrictions, or both. Or culturally, in China, 29% of mothers only breastfeed because it's more nicely seen to bottle feed because that means wealth. That's bizarre. So
Or even a
breastfeeding is
lot of
important.
females are working and
They
get
have
right
to
ready.
work.
Right. Yeah.
So that's your first, but then the second opportunity is when the first molar is coming. That's at the age of 5, 6. And then the other opportunity is when they are in late mixed dentition, when they are 9, 10, when you expand, and then the canine premolars are erupting. So that are opportunities where you can lift the bite and new teeth start to erupt into that new space. So if you wait too long, what happened is the deep bite stays a deep bite. The lower teeth go backwards and up. We cause a curve of Spee, we call it, with a lot of wear on the front teeth. The hardest thing to treat with clear aligners in adults is a curve of Spee biomechanically. So every dentist, every orthodontist waits for the curve of Spee to happen to then struggle to fix it. How stupid is that?
And I have 2 questions. One is for maybe some therapists might not know what a curve of Spee is. If you could explain that, and maybe parents aren't aware. And then my other question tied to this, I'll ask it again just so I don't forget, but it's on my mind, is we're talking about opening the vertical. But I know a lot of practitioners say in young child, let's just expand. What's the order of expanding versus opening vertical? And is that a different philosophy?
Good question. So it's all about adaptation and compensation to an airway problem. Okay, let's start from the beginning. The tongue is low for whatever reason it is. We had tonsil adenoids who push the tongue down, tongue tie, whatever. The tongue is low, we are mouth breathing. That means the upper arch is now not getting development because the tongue is your expander. So we get transverse collapse and sagittal collapse. So AP correction and transverse correction. So the sagittal compensation in the upper needs to be compensated with the lower sagittal compensation. That is, the lower front teeth go backwards and up. that creates a discrepancy of the back teeth and the front teeth in height. And that discrepancy, this curve, is called curve of Spee. It's a sagittal compensation curve to a sagittal compromised upper jaw. Now we have a transverse collapse as well. So the palate goes transverse collapse. The lower needs to adapt. How does that adapt? The teeth tilting in.
Okay, wait. This is so good. Question that I have to pop in here. Curve of Wilson. Okay, as a
Correct.
speech pathologist, we don't learn about this, but there's this like Facebook post happening right now, and people are chiming in. And my question is, how upright should the upper and lower teeth be? There's a picture of a 6-year-old. The lower teeth are tipped lingually, the upper teeth are tipped buccally, and I was
This is
saying
bad.
that the teeth appear in compensation due to the narrow palate, but this is my opinion. I'm not an orthodontist or a dentist. And the person
Okay.
posted said that's called curve of Wilson. That's normal. I don't know. How do you know how much is normal?
So the transverse, when the upper jaw is collapsing, the lower teeth need to be biting, functioning, otherwise we're dying. So the teeth tilting in. That's curve of Wilson. The
And that's
transversal,
normal because
well,
okay.
no, normal to a certain degree, but it's very extreme. So the upper expansion, so now we have a sagittal compensation curve, Spee, transverse compensation curve, Wilson. So now, how do we correct that? The upper can be expanded, but it can only be expanded that is still in contact with the lower. Otherwise, we have a scissor bite. We don't bite at all. So when we expand the upper, now it gets interesting, very complex. When we expand the upper, we always need to consider the lower. So we should upright the lower to where it should be, straight up. And then we have the right reference for the upper expansion, bone expansion. So what you just said is the upper teeth are flared out. That means the base, the bone base is narrow. And the lowers are tilted in. So that means the bone base is wide. So now we have a discrepancy in the bone of upper and lower. So that makes me, I need to address the bone in the upper. So I need to widen the bone to then tilt the upper teeth back in because they are flared out. And this is the problem a lot of orthodontists are doing wrong.
Yes.
Because if the base is narrow and you align teeth, you flare them.
Right.
And when you flare them, you don't respect the bone. You
Mm-hmm.
might get more tongue space.
Yeah.
So the tongue can go up and forth, which opens a bit of the airway. But it does not increase the base of your nose. So
Exactly.
diagnosis is key. Is it
Okay.
the bone or is it the teeth?
Right.
But
Okay. So can you help me with the curve of Wilson? So what the person said to me is if the teeth are completely upright vertically, then you would run into issues in lateral excursions. However, what is the amount of curve of Wilson that's normal, or how upright should the teeth be in a 6-year-old?
right. First of all, we have to consider a 6-year-old needs to have good suction hold with the tongue. So the tongue needs to have enough space in the roof of the mouth to fit in. Because without suction hold, the tongue will drop. We have airway issues. So the upper needs to be wide that it fits the tongue functionally. So then the lower needs to fit to that. And in a perfect jaw, this fits together because the tongue and the palate, they get the same stimulus, the same tongue. But in our generation, we have a different problem. We're shrinking. So what they talk about is static guidance. Forget all this static canine guidance, group guidance, all nonsense. We need to function. And when we function, the first thing is we need suction hold. We need enough space for the tongue to be sucked, not with muscle tension, because nobody has enough strength to keep it up there with muscle fiber. We need a suction. For that, we need a flat roof palate, because like a drop of water between two plates. Otherwise, we cannot suck. Otherwise, we consume too much energy. If the brain uses too much energy at nighttime, when it's sleep, it drops. Too much effort. So the most important thing is enough space for the tongue. That means the palate needs to be as wide as the tongue requests. Another interesting thing is about the tongue. When we increase in weight, the tongue increases. So that means that can change the size of tongue in lifetime, depending on your diet. But that's a different topic. So what is ideal? We need to get away from dogmatic thinking what's ideal. 10 degrees, 5 degrees, 38 millimeter, 40 millimeter, who cares? It's about function. How do we, because sometimes people have a small tongue, they need less intermolar distance. Sometimes they have a big tongue, they need more. So what I'm saying is what we see is adaptations. The tongue is low, the upper collapses, the lower will adapt. And when it cannot adapt anymore because the tongue isn't there, we develop what? A crossbite. Because the tongue is there. It can't collapse anymore. So the upper collapses more because of the pressure of the cheeks. So we develop a crossbite. Then even dentists understand, oh, that's now a reason for treatment because we have a crossbite. Too late, mate. You missed the opportunities.
Too late, mate. Like that. Right. And if there's not a dental crossbite, I think people aren't aware of the concept of skeletal crossbite that I've learned
Right.
from being in this airway
Because
space.
it's adaptation.
Yeah.
Like I can
Compensate.
flare the upper teeth out and the lower's in. We have no crossbite, but the base is narrow.
Yeah.
So if you put them correctly, you will have the crossbite, and that is they just adapted really well to that. And sometimes people with the same problem have different symptoms or no symptoms. We don't know. Some just deal better with it than others. That's just human nature.
Yeah.
So, but we need to look into a patient. We need to see how are they working and how are there any symptoms. And just if some have symptoms, we know what to do. If they don't have symptoms, they might not have symptoms yet. They might never develop symptoms. Fair enough.
And when
But
you're talking about symptoms, you're not just meaning like aesthetic or dental, but you might be meaning like behavioral, like beyond grinding, but like snoring, ADHD.
absolutely.
Yeah. So in this particular case, I just want to ask because it's really helping me understand how to like view when I'm looking at teeth and angles of teeth and tipping. Like this particular child snoring and had hyperactivity. And people are just kind of arguing, oh, that has nothing to do with the occlusion. But then as people are looking at the photos, are like, this is a class 2 malocclusion. You should treat. And some people are saying, no, don't treat. That's a perfectly normal 6-year-old mouth. And they're saying, oh, refer to ENT. Like, but this is a holistic treatment. Yes, we refer to ENT. Yes, we do myofunctional therapy. But what is the orthodontist role? And I do remember Dr. Kevin Boyd saying, whenever there's a class 2, there is a narrow palate. Is that opinion?
Okay,
Is it
that's
common clinical
number one.
evidence?
A new study by Derek Mahoney. You need to have him on the chat. He
I just
published
had him before that study came out, by the way. He was talking about the study I'm publishing. So yes.
it. 3,700 children. The ones with the class 2 face structure are the ones with most likelihood of sleep disorder breathing. That's fairly a lot of patients. So, class 2. Let's go back. The tongue is low. We are mouth breathing. The jaw is developing backwards and down. So the upper jaw is collapsing. It becomes narrow. So now, the ladies like to wear high heels. Can a foot slide forward when high heels? No, it cannot. When the upper jaw is compressed, the lower jaw cannot grow forward because there's no space to grow it into. So it will be recessed. So when you know that, now they always say, okay, the lower jaw is growing with puberty. That's the peak of mandibular growth. Correct. But these years before puberty, they're still growing in tiny little waves, about 1 to 2 millimeters a year. So now if you have a 6-year-old with a 10 millimeter overjet, distance between upper and lower, and you say, let's just wait. Then you have only the puberty peak to correct 10 millimeter. You will not. You might correct 2, 3, 4 millimeter. So you're still 6 left, so the lower jaw is recessed, which is your sleep disorder breathing. But if you start...
just to throw in the puberty piece, there is research showing, at least in males, the size of the tongue enlarges significantly around puberty. So a lot of those males that were cured of a sleep apnea at a young age have relapse around puberty due to that factor as well. So we need intraoral space as much as possible.
Course. So now, but also you have missed this opportunity to bring the jaw forward very tiny bits in the years before. But also what people forget is how compliant is a teenager in wearing elastics or mandibular advancement device. I can tell you they're not, because they're teenagers. A 6-year-old kid who gets bullied at school because of protruding teeth, trust me, they will wear anything I tell them to. So they're the most compliant patients you ever treated. So you focus on growth development, you forget the big part before. And you focus on compliance, it's a nonsense to treat teenagers. So by the age of a teenager, you should have done your job already and just maintain and supervise growth. But if you missed all of this, you're just fixing. And then you need to rely on a kid to help you with. And that's not happening. So class 2 is number 1. Then we have the B retrusion. The class 4, Kevin Boyd is calling them. So now the upper is recessed because the tongue is low. The lower doesn't fit in either. That's also recessed. So we have B retrusion. That's also a massive facial structure for sleep disorder breathing. And the third one is class 3. So let's talk a bit about class 3. So now the upper jaw is so constricted, and AP, transverse compensation, sagittal compensation, that when the teeth are erupting, that the upper teeth are erupting lingually and the lower teeth touch and slide forward. So now the lower jaw slides forward. So it's a functional adaptation to the narrow upper arch. So that means we have a recessed retrognathic maxilla. So now if we do the cephalometric tracing, the data, which every orthodontist should be doing, we look at SNA, the structure, how the upper jaw is situated in reference to the cranial base. And we look at SNA is negative, we call it retrognathic. But sometimes they're both retrognathic, and SNA and SNB are normal. So we call it skeletal class 1, but both are retrognathic. It's also not good. So class 3s are most likely pseudo class 3s, which means the fault is in the upper, not in the lower. And the lower, when we register the B point, is a functional adaptation. So the position is more forward than it is in relaxed position. So it's false. And also the thing is, now research. Let's go into this nice topic of research. According to research, we cannot make a mandible grow. That's what people say. Okay, let's accept. But what we can do, when we have a deep bite, we can open the vertical, which gets them out of constriction. So functionally, the jaw will come forward because it got pushed back. That has nothing to do with growth. But also what we can do is, if we cannot make the lower jaw grow, but what we can do for fact research, we can make the upper grow because we can make the upper expand and protract. And the earlier we do it, the more time the lower has to grow into that space, into the foot, into the shoe that is much more forward, gives the feet more space to grow. Like we buy our children shoes every couple of months because their feet are growing. If we don't buy them shoes, the feet don't grow.
And when we're saying clearly the mandible, it can't grow, in that case, it can unlock or come forward. So where is that change occurring? Can you talk about that when we unlock the mandible?
When we have a deep bite, the jaw gets pushed back. So the joints, the condyles, getting pushed into the fossa backwards. So what will happen is the head will come forward. Because here, the lower jaw gets pushed back, so the lower part of the airway gets tight. Lower airway obstruction. So compensation is head posture. So when we open vertical, the joints get released, so they come at least 2-3 millimeters forward immediately. The airway opens, head goes back. Now the tongue goes up. Tongue is just stimulus. If the floor of the mouth is lifting, the jaw gets stimulated to come forward. Function follows form, or form follows function. So it all plays a role together. We just have to consider everything. And the earlier you detect the first problem, the more time you have for nature to correct. If you wait too long and wait and see, your window gets really small. So you cannot correct. So then you say, okay, you have an overchat of 8 millimeters. You might be correcting 2, and that's it, game over. Now you need jaw surgery. Who does jaw surgery? Nobody. Costs too much money. So we have the opportunities to intercept early. Now we say, okay, it's all genetics. I have a class 2. My daughter will have a class 2. Yes, we all have a genetic component. But the minute we are born, epigenetics plays a role. And there's a huge discussion in the whole world on universities. How much is genetics? How much is epigenetics? In England, they believe everything is genetics. So you can't do anything. It's in your destiny. So, but then you go to Italy, the professors say the opposite. It's all functional. So what is it? For debates, I would say 50-50. But whatever percentage is epigenetics, you have opportunities to address the epigenetic by releasing the bite, stimulating the muscles, get the muscles strong so that form follows function. So it's so complex. You just have to be open-minded and to understand these opportunities you have before the age of 10 are so big in every aspect of life. And it's not about finding these reasons for treatment of cross bite, deep bite, open bite. Who cares? What are the symptoms the patient is presenting with? Why do they come? If they snore, there might be a problem that when we expand the palate, it stretches the soft palate. So we might get rid of the snore. We increase the nasal base. So we just have to be a bit more open-minded. And for my colleagues out there, sometimes you need to read papers that are not orthodontic papers. You need to read sleep medicine papers, ENT papers, and other papers because it's in other papers published. So,
Okay.
and also AI helps you nowadays very quickly to get research if you wanted to.
It really does. You just ask, show me all the studies of blank, sleep disorder, breathing, class 2 malocclusion, and it will tell you everything, which is amazing. So I guess the orthodontist or whoever's who has this patient needs to actually see it as a problem. But if they see something as normal, like that's normal angulation of the teeth, or that's the curve of Wilson, that's normal, then they're not seeing it as a problem, so there's nothing to correct.
But okay, let's talk about these angles. So we do a cephalometric tracing. The lower teeth are, or the teeth are proclined, B protrusion we call it. If now we just would ask, what could be the reason for these teeth being proclined? There can be only one reason or two reasons. It's a habit, a finger, which you need to treat. Or it could be the tongue that is thrusting. So then you need to ask, why is it thrusting? Is there not enough space for the tongue, so it needs to go forward? Or is there tongue restriction that causes the movement? That's as simple as it is. So if you just look at the data, you can measure intermolar distance, you can measure angulations. So if you now say, okay, there's protrusion, if the tongue is the reason for that protrusion, and I recline these teeth, how likely is my stability? Very unlikely, because the tongue is still the reason. So if we just know how to analyze the numbers we're measuring, this is what, when I teach in my courses, I teach in a way that people understand what they need to look out for in a cephalometric. For example, if a kid has a tongue tie, I expect, because their swallowing is incorrectly, that the teeth are proclined. The cephalometric will just confirm what I already know. When we have a class 3, I know the upper jaw is underdeveloped. That's how it developed the class 3. So I know the A point should be retrognathic. I just use the value SNA as a confirmation. So the cephalometric is just supporting my argument, what is the problem in the first place. But sometimes we get misled. So the data doesn't show us what it is, what we're seeing. So now we sometimes believe AI, right? So when we were students, we traced them manually, a cephalometric. 30 students in the audience, all with the light box and the Bausch paper, and traced it. From the values we took, from 30 students, we had 30 different values because they did mistakes in finding the points. So now using AI doesn't eliminate the mistake, because you give 2-3 different AI softwares the same cephalometric, they will give you different values. So you can be misled by the points that have been chosen are incorrect. So we are just getting fooled by technology, or we're getting fooled by companies who want us to sell a product. So now the next thing is, a company, mainly clear aligner companies, they're showing how teeth are moving. They're not showing you the palatal shape. But we know the palatal architecture tells us where the tongue is. But the companies are not interested in the tongue. They're only interested in the teeth because that makes the money. So we need to get away from this foolish behavior of following a company who wants to sell a product. We need to understand what's going on. And if we understand that, the teeth will adapt naturally to a good position. Or if we need to treat a structure and we do the function, we will realize we get stability, long life stability. Function is your retention.
Function is your retention. I feel like I put myself on mute because I'm like literally repeating everything you say. I'm like, function is retention. I'm writing notes. I took myself off mute and I'm like, wow, I'm speaking out loud. Everything you're saying, I'm like repeating it.
Like
Function
this is so key, but we getting taught at university long life retention. Nonsense. We get taught at university, put a fixed retainer on, put a prison on the teeth, which doesn't allow any kind of movement. So instead, what I teach is, we need to have a trial run. So when my kids are finished, we have myofunctional therapy. We try to improve function. And then I ask them gradually to reduce the wear time of the retainers to assess stability. If I have stability, I don't need a retainer. If I have movement, I have two choices. Either they are not doing their exercises, or they get a nasal swelling, hay fever, and they fall back to mouth breathing. So there's a reason why there's instability.
And that's assuming you put the teeth in the right position for the jaws. But other practitioners might not be doing that. So patients might be getting relapse if they're not wearing their retainer because they're like, for
The function
example,
gets up.
yeah, I'm just going to tell you about myself real quick. I wear a Holly retainer upper and lowers every night because my parents told me I have to. So I'm a really good patient. Okay. So I wear those and I didn't wear them for like a week. And I put them back in and they were so tight. I think, tongue's a little forward, don't have enough good space to breathe. My jaws were not put in the right position. So perhaps that tight feeling is because my teeth started flaring because my jaws aren't where my breathing needs to be. But treated from an airway perspective, we would probably not expect such relapse if the function is also corrected. So here's my question for you. We talked about genetics, which obviously has a role. We talked about epigenetics, which no doubt has a significant role, that nature versus nurture. So do you feel most orthodontic patients need myofunctional therapy?
All
Okay.
of
All
them.
orthodontic patients. Okay.
At least an assessment if function is correct.
Right. And we know, we believe, like Dr. Derek Mahoney, others, Herman Ramirez, many who understand this concept, that oral dysfunction is a cause of malocclusion. It's obvious to us who see it. So if we correct the malocclusion, but not the oral facial dysfunction, then there's a high risk for relapse.
Correct. But what we have to say, sometimes, especially when we treat young children, the function can adapt to the new structure by itself. Like it adapted before in a compressed function, the function adapts to that. When you now give the tongue space, sometimes it comes to recovery by itself without myofunction. But also we have to say it's so complex that sometimes things change seasonally.
Yes.
Right? We have hay fever. So when the time comes, the mouth is blocked, the tongue falls into down. We adopting mouth breathing habit, it comes back. So it's a consistent reminder we need to do it.
A
It's not a
lifetime.
one-time exit, lifetime.
It's a lifetime of reminders, and not like it's this horrible task or chore, like myofunctional therapy is a black hole that never ends. No, but our bodies are always changing. And in myofunctional therapy, we monitor our patients for allergies, seasonal or congestion, right? Is it seasonal? What's happening throughout the year? And the patient can become independent and monitor that on their own, and they know what to do if that occurs. But things are always changing. Adenoids can grow back. Males, puberty time, tongue enlarges, and then there's those issues. Someone can get hit in the face with a football and then they break their nose. There's always things that
Of
can
course.
affect functioning. Even dental treatments. We had a patient who had a root canal and the tooth was hurting a lot, so she started chewing on the other side and developed a lateral tongue thrust in her mid like 50s, and then developed an open bite. And so things are all, function is always changing or can be changing, and our bodies are changing. So we have to be aware of what's going on as we get older. Muscle tone can drop, right? And other issues can occur. So yeah, it's not a
And
one-stop.
I give you an eye-opening thing that happened this year. My wife is Indian, and she invited me to see where she's coming from. So I went into Punjab, North India, into a village. Village, like basically you think 300 years ago, still the same village. So we went into this community, and with basic lifestyle, there was no Western influence at all. No KFC, no McDonald's, nothing. So her uncle, 6 o'clock in the morning, he walks to the temple to be grateful to God, gives his food. Then he prays and he does pranayam breathing exercises. And he starts sitting there in front of me, and he does tongue exercise. And he goes, I said, what are you doing? So every day, without a miss, he goes for a walk, he sees the sunlight, barefoot, prays to God, and he does myofunctional exercises and breathing exercises every day. Guess what? There was no problem. Basic lifestyle. I was sitting there with my mouth open. I said, oh God.
You're a mess. I can look.
How simple does life need to be? We forget everything of that. We are such in a rush that we don't do any of it. We're not grateful to what we have. We don't walk barefoot. We don't do look at sunrise and sunsets. So we do everything wrong because the industry tells us to do so.
I have a funny little story. My 11-year-old son just made a new friend in his class, so they've been hanging out, and this boy came over to our house and he is adorable. He's got the hugest smile, the widest smile, full teeth showing. And I'm like, who is this kid? And we're hanging out during the day, and the kid's popping his tongue, like lingual palatal suction, but for fun. Okay. But the loudest pop you've ever heard, and I've heard kids do this before, but it's like that, like, I can't even do it. So loud that it's like a little skill this kid has. And I'm like, how long have you been doing this? And he's like, no, a couple years. And so now my son's trying to imitate him. And I'm like, oh my gosh, I bet that kid, he's been doing lingual palatal suction. He has no idea because he's having fun. That's probably why his arch looks so beautifully developed and wide. It's so weird to see that.
And I give you another story. I had a 5-year-old patient, tongue tie, mouth breathing, obstruction, but the palate was flat, no crossbite. So I was very confused that I expected a high voltage palate crossbite, but doesn't fit into my red flags. Who are you? Who is the mom? She said to me, I'm a craniosacral therapist. And I knew that my son is mouth breathing. I knew there's a tongue tie, and the only thing I knew how to do it is to stimulate his palate. So since he's born, he's massaging the palate every day. The palate was flat. So this is where I learned in the Down syndrome I seen today, please just massage the palate every day.
Yeah, well, it kind of sums things up, thinking it's not necessarily a lot to make things go the right way at a young age, but it's
Lips,
not a lot
tongue,
to make it go
breathing.
the wrong way also, right? Little things can take things totally off track, but little things can also help significantly as long as we get to the kids when they're young. Because as we get older, things get more ingrained and it's just a lot harder to fix. But
You
those
see
are great stories.
small opportunities
Yes.
you cannot miss.
Yes.
And that is the key to everything. This is what I preach every week about. It's all about missed opportunities. It's not about the teeth.
I just got a chill. It's not about the teeth. It's about missed opportunities. It was a good chill. That was a good chill. That's amazing. Let's not miss these opportunities. We all need to see these signs before they become symptoms. Everything you said, we can intervene early. It's going to be easier, more opportunities than waiting.
You see the smoke to prevent the fire. If you don't see the smoke, you have to deal with the fire.
Mhm. It's Samantha Weaver did a great presentation I've seen about that, and she shows the smoke when it wasn't dealt with turn into a fire. And these issues in our adults, we can see if you look back on childhood photos, in a lot of cases signs were there and it just became progressively worse. And when I talk about myofunctional disorders are progressive. If left untreated, they're going to get worse. They're not going to automatically get better if we're ignoring them. So
But I
just
want to
like
say at the end also one thing. Sometimes life is hard and we're getting stressed out, and we have to make sure that our kids are safe, or other priorities in life are there, there's separation, whatever. So me myself, I missed a lot of opportunities in my children because my life was hard at the time, so priorities were different. So as a parent out there, it's okay, don't blame yourself to miss opportunities. We are here to help. At any age we can still help. But
mhm,
if you have friends with young children and have symptoms of small opportunities, tell them they should get help, or at
yes,
least to be seen by one of the professionals. But we are only humans,
yeah,
and we are here to educate. But you cannot blame yourself for missing
yeah,
opportunities because you might have tried and you got the wrong answers, or you have been told to wait and see. That's
yeah.
not your fault. So we are
Or you
here
were
for.
so burnt out because your child was difficult. Like, my
Correct.
kids are all messed up, but I'm here to help your kids. Everybody else, don't look at my kids. But yeah, we're busy, it's hard, and it's so much easier to guide others than sometimes what's happening in your own family. A lot of our airway children have behavioral issues, and it's
Of
not so
course.
easy as a parent to manage both. So, yeah, it's exactly. Don't worry about my kids. I'm here to help yours because I couldn't do it all for my own kids. And it leads me to one other last question for you. Are we okay on time? Like a minute, too
I'm
much.
fine. I can talk
Okay.
about this all day.
I just totally held you way longer than you expected. But this is just so good and juicy. But what I'm thinking is, I had a parent, 8.5-year-old, 12-year-old, two daughters, was emailing airway cases, talking about, consultation for myofunctional therapy. But they also went to the orthodontist. And she said, I understand my kids are going to need both orthodontic treatment and myofunctional therapy, but everything is just so expensive that we're just going to pick the orthodontic treatment. And it just it's a lot. How do parents handle this financially? How do we help as practitioners? People need to pay rent,
This is the
employees.
saddest thing, Nicole, I have to tell you, because if I would get everyone involved in, I think who should be involved, it is a luxury good. Craniosacral, speech, myofunction, orthodontics, dentistry, also. And this is the saddest thing about everything. Health is luxury good. So again, the earlier you catch it, the less money it costs. In a baby, it's just massaging the palate or button to train the lips or things like this. So how do I manage? I try to find ways to not use human resources for things, meaning AI. So exercise, like when someone comes to me and I have a lot of patients who traveling to me, I have AI software that monitors their treatment. That means it allows them to be far away and I can take care of their treatment. Number one. Through that software, I can send automated videos of instructions to do exercises. So every evening at 7 p.m., they get a reminder, have you done your suction hold test yet? Here's a reminder how to do it. Then they can send a feedback back with a video and I have a look at it. That costs nothing. So also I can put a button into my box with a thread on. So I can do a lot of things and use AI technology to release my time as well because it's valuable. So this is where you can save money. But sometimes for especially consultation to develop a plan, a lot of people need hands-on. They need to feel. That costs money because it's human resources. This we cannot avoid. But AI can help you now. Also online in YouTube, there are mewing exercises. There's a lot of things out there for parents to get resources cheap. Also, Mike Mew is a colleague of mine in UK. In America, everyone knows mewing. There he has an app called the Mew app to download. So we can support Mike in his mission to fight back, but also gives you valuable exercises. They cost a few dollars. So there are ways out there to get cheaper access to help. But I agree with you completely. Health is a luxury good. And that's why my vision is sometimes you have to do something for charity. That's
Right.
when you are in that space,
Yeah.
you
And
cannot pick and
perhaps
choose.
and perhaps at one point some of these services will be covered by insurance, like they'll realize the orthodontic treatment is not just cosmetic, even though that is extremely important, but it's long-term health
But you
goals.
know, Nicole, with this insurance, there's a lot of lobby and politics behind.
Yeah.
There's money. Pharmaceutical industry need to make money. So that will take a long time. But it's about supporting each other in the community. And with really minimal means, you can have a huge impact. Just give the kids good food to start off with.
Mhm.
Don't get rid of this soft diet. Make them breathe. Probably take the time to educate your kids. And these are easy things. They're free. Go for a walk in the sunshine, in the forest. They're
Mhm.
free of charge. I mean, there's things you can do.
Right. And if we can get this information to schools, perhaps in curriculum, there could be little times in preschool where kids are taught sit up straight, lips closed, breathe through your nose, like maybe, myofunctional therapy getting
We
into
do that.
school.
Make the
Yeah.
sound. Make it like your
Yeah.
your boy.
I gotta record that boy. Those
Do
sound, oh my
it.
God.
Put it
I'm
on
not,
your podcast.
yeah,
100% because this is so easy. It could be
yeah,
new viral video.
yeah. If you saw his smile, there's something so captivating about him when he smiles. I'm like, it's because
Make it viral, Nicole. I support you. Honestly, if that becomes viral, we help a lot of jaws.
Yes. Well, actually, I'm writing a children's book. It's almost ready to be published. So hopefully that can get into schools and it teaches some of these things as a fun, resource. But I really want to thank you, Dr. Decker, for all of your time. We were like almost an hour and a half. So I really appreciate you providing all this insight and passion, information, spreading this message. Continue to do so. You've got this. Thank you.
Thank you for having me. And if you need me, I'm the orthodontic specialist on Instagram. Follow me and my story, and I'm here to help. Thank you, Nicole, for everything.
And you teach as well. When I went to your website, there are a bunch of courses. Are there virtual
we have
courses?
the Orthodontic Specialist Academy as well. So my mission is also to train my colleagues in the world, wherever they are, that dentists can treat their own community. Absolutely. Reach out to me, the Orthodontic Specialist or Orthodontic Specialist Academy. Follow me on social media.
Okay, I'm going to put those links there. Thank you so much. Have a great rest of your night. I really appreciate it.
Thank you. Thank you for having me.
Thank you. Thank you so much for joining this episode of Airway Answers. I'm hoping some of your Airway questions were answered. Please feel free to give us a rating or a comment. And if you have any further questions, you're welcome to email me at nicole@airwayanswers.info or check out our site at www.airwayanswers.info. Thank you so much and join us for the next one.